Okay, good morning, good afternoon, and welcome to this policy laboratory focused on building momentum on obesity in Europe. This webinar sees the culmination of a 4-year programme of work which has been funded by the European Union. It has included a series of policy laboratories like this one, which many of you have been attending, and we're very grateful for that and hope you've found them really interesting. We've also published a series of policy dossiers covering a wide range of policies that have been identified for helping to address obesity around the world. In addition, we have been able to expand our training programme for health professionals with the development of new and innovative modules, and we have also been undertaking a huge review and upgrade of our Global Obesity Observatory, which provides data on obesity prevalence and its drivers. The policy component of this work has collated evidence for action and effectiveness of particular policies such as SSB taxes, food systems, physical activity, and city-level interventions. And importantly, we have been able to showcase best practices from Europe and around the world, with the goal to support policy development and reduce obesity. In this particular laboratory, we want to take stock across a range of these policy issues that we have focused on and explore some of the cross-cutting themes and experiences that we can take forward through obesity policy. We also want to discuss how we can better collaborate to achieve our shared goals. Today in this webinar, we're going to start with 2 very brief scene-setting presentations, one looking at the need for action and prevalence of obesity in Europe, and the other on policy implementation. And then we're going to go into a series of case study presentations, and then hopefully a lively panel discussion, which is going to be moderated by my colleague. So before I introduce those first speakers, just a few housekeeping points. Please post any questions that you have for the speakers or the moderator in the Q&A, and any comments that you may have into the chat. Both of these are being monitored, and we will try and address any of your comments or questions. The webinar is being recorded, and we're going to make it available online after today's event. So please do look out for that link and share it with any colleagues who you know have not been able to attend. So I don't want to hold up the start of this webinar for much longer. So I am going to hand over to our first speaker today. I'm delighted to present Kremlin Rikran-Singer, who is the acting head of the European Office for WHO in the Prevention and Non-Communicable Disease Department. And he's going to present Obesity in Europe, the case for action. Over to you, Kremlin.
Thank you, Hannah. Thank you for the invitation, and I'm delighted to join the webinar with many other panelists and the other stakeholders to talk about the obesity and why we need to act. As Hannah mentioned, I'm joining from the WHO Regional Office for Europe, NCD office, where we have NCD risk factor works, which include obesity and physical activity as well. Next slide, please. So as a quick introduction, I wanted to show these 2 slides from 2 surveys that we are closely associated with. First one, the COSI Childhood Obesity Surveillance Initiative, which involves more than 40 countries in our region, where it allows us to compare the percentage of primary school children living with overweight and obesity. And as you can see, in many European countries, especially EU countries, we have nearly 30% or close to 40% of primary school children living with overweight and obesity. In the WHO European region, we have 53 member states, including more Eastern European countries, former Soviet Union countries, where this prevalence is lower compared to Southern European countries. But the rate of increase is much faster in Eastern European countries. So we need to act faster, and it's the same situation with the health behaviors of school children survey, where we look at 11 to 15 years, we see a similar pattern, very high level of percentages. Next slide, please. And recently we tried to compile all the information we have from COSI into a supplement of obesity reviews, and it was launched last week, and it's available now. And we try to present the data, trends, some of the socioeconomic factors, and importantly, some policy actions taken in our region. So you can see what are the innovative policies and which countries have used childhood obesity surveillance initiative data to inform their policies, but at the same time, more importantly, where the gaps are and where we can further improve our policy work. Next slide, please. We are trying to build the current situation in our region into a WHO European report on obesity, which we will launch 4th of March next year. We are trying to bring all the data we have for primary school children, adolescents, adults from obesity estimates of WHO, and then talk about the current policy implications, evidence from obesity to cancer, and also gaps in policy implementation. And we are going to compile this to a report and launch it. And we really hope this report will be able to serve as a starting point to accelerate the progress and also identify where we can put our energy in the coming years. Next slide, please. In our Ending Childhood Obesity report, we talk about many areas, 6 key areas where we need to focus on and subcategories within them. In one of the papers in the Obesity Review supplement, we tried to map which countries have implemented all these 6 areas. And it's unfortunate that we can't map a single country which has implemented the full package of these interventions. Yes, we have very good countries championing certain policies, 1 or 2 policies, but we cannot see the whole package, including obesity management and prevention, all of that together in a country. So what we really want is to organize policy dialogues and going forward to encourage member states and all stakeholders to look at a whole package and implement them together. Next slide, please. And in the WHO Regional Office for Europe and in the NCD office, what we are trying to do is link this. We know that obesity has a life course approach, and if we really need to tackle it, we need to work together with many sectors, but also connect our own work. Promotion of nutrition in the maternal field, breastfeeding, complementary foods, implementation of the code, restriction of breast milk substitutes, and then marketing restriction, school nutrition, provision of water to tackle sugar drink consumption, schools and workplaces. And we want to link all these packages and really provide necessary tools to tackle obesity, and including challenging areas such as digital marketing. Next slide, please. Yeah, I'll stop here. So basically, we know the current burden, we have data, we know the current policy implementation, which shows us there are many gaps, but at the same time, I think there's a renewed enthusiasm to work in this area, and especially take the opportunity with the cancer initiatives that we have in the EU and really put all of our energy and bring stakeholders together to accelerate for prevention and management of obesity in the region. Thank you very much.
Thank you very much, Kremlin. It's always good to hear from WHO Euro. And I think the point that you made about the need for package of policies is really, really key. And one of the things I think we need to work on more is understanding how these policies fit together and how we can collaborate to ensure that we do get these packages and not just sort of a piecemeal approach to obesity. So hopefully that's something that we can touch on a bit later. So thank you very much. I'm now going to hand over to Stephanie van der Veer, who is the Senior Public Health and Nutrition Scientist at Science Sano, based in Belgium, and a member of the STOP Consortium, which is an EU Horizon 2020 project focused on childhood obesity. And today she's going to present some innovative policy insights from the STOP project, which gives a good oversight of some of the actions and inactions at a national level across Europe. Over to you, Stephanie.
Thank you, Anna. Hello, everyone. Good afternoon. So I'm going to give a quick overview on policy gaps and recommendations across European countries based on an assessment that we did using the Healthy Food Environment Policy Index, which was funded through the STOP project, but also the GPI Policy Evaluation Network in Europe. So the idea of this tool and process is to gather comprehensive evidence on extent of policy implementation by national governments, and then using that evidence, assess the extent of implementation compared to international best practice. And from that, derive some key priority actions for future implementation. So the Food AP was implemented in 10 European countries and also at the European level with strong involvement from experts and policymakers. Next, please. So there are about 24 different good practice policy actions that have been identified to create healthy food environments. So the slide basically shows in a simple way the proportion of those actions at very little, if any, low, medium and high implementation compared to best practice across the European countries. And we can see, as Kremlin already mentioned as well, that there is no European country at the moment taking very comprehensive actions and scoring high for the majority of policies. We can see some variation across countries. So we can see that the countries with the highest proportion of policies at very little or no implementation are Germany, Poland, and Slovenia. And countries with some policies rated at the level of best practice are Norway, Portugal, Spain, Slovenia, Estonia, and Finland, with Portugal and Finland having the most policies at the level of best practice. And at the European level, no policies were evaluated at the level of best international practice. Next, please. So what are some of these best practice policies in Europe? And of course, I'm saying best available practice, as it does not necessarily mean ideal practice. But some countries that got rated well, for example, have a front of pack label in place, such as Nutri-Score in Spain or the Keyhole logo in Norway. Some countries have mandatory regulations on marketing to children through broadcast media or in schools. An example is, for example, Norway, where the Broadcasting Act states that advertisements may not be broadcast in connection with children's programs, nor may advertisements on television or in audiovisual on-demand services specifically target children under the age of 18. And the ban includes any product, including all foods and beverages. Some best practice policies also include nutrition standards in schools. An example there is, for example, Finland, where the Act on Early Childhood Education and Care outlines that children shall be provided with healthy and necessary nutrition that fulfills their nutritional needs and provided a meal free of charge on every school day. And so children at kindergarten childcare are entitled to a meal each day. And so there are also specific nutrition standards for these meals. And then there are also some reformulation policies, but to be fair, most of those countries that set reformulation targets, they remain voluntary in nature, apart from perhaps salt levels in bread. And so the experts identified some priority policies across those countries, and the top three are fiscal policies, so to have taxes on unhealthy foods, but also indeed setting nutrition standards in public sector settings, in particular schools, and more comprehensive regulations of unhealthy food marketing to children, so covering all media and not just broadcast media. Next, please. And at the European level, there are also many gaps that were identified, and there the experts also provided some recommendations for the European level jurisdiction. For example, that member states are required to implement restrictions on bans on the marketing of unhealthy foods through digital media and on food packages, that member states are allowed to implement a VAT exemption of 0% for all fresh fruit and vegetables. Also, the European level was recommended to set mandatory, ambitious and comprehensive reformulation targets for processed foods and meals sold at quick service restaurants. So these are some examples. There are a few more on the slides. So I'm looking forward to a fruitful discussion in the panel. Thank you very much.
Thank you very much, Stephanie. And it's great to see the food epi work really becoming more widespread and at the point where we can start comparing countries and start understanding some of the best practices and where there can be sharing between countries to try and get better infrastructure and things like that. So thank you very much for that insight. And I look forward to seeing more on this in the future. If anybody has any questions for Kremlin or Stephanie, please put them in the Q&A and they will be able to respond hopefully at some point throughout the rest of the webinar. I now have the pleasure of introducing Simone Barcara, who will be moderating the rest of today's webinar. Simone is a member of the World Obesity Federation's Policy and Prevention Committee and is Executive Director of the Nutrition and Health Research Center at the National Institute of Public Health in Mexico. We know that Mexico has a really big problem with obesity, but also that they've taken a lot of steps with some of the policies that they've been implementing there. So it will be good to get Simone's perspective. So Simone, I hand over to you, and I hope everyone enjoys the rest of the webinar. Thank you.
Thank you very much, Hannah. It's a pleasure to be with you today. Thank you for the invitation to the World Obesity Federation. And I think today we are covering a very important topic, which is what are the best policy options that we have. And as you see, Stephanie has just mentioned different strategies and policies that can be implemented to improve the food environment and to improve the conditions of the population to prevent obesity. And today we are going to review three case studies that are very important. First, two of them has to do with child obesity prevention, and one has to do with attention with healthcare and obesity. So we are going to start by listening to Alexander Peck from the Department of Health and Social Care. He's head of Healthy Weight and Nutrition Strategy and Program Governance at the Department of Health and Social Care in the UK. And he's going to talk about the evolution of childhood obesity strategy in UK. Please, Alexander, the floor is yours.
Thanks, Simone, and hi, everybody. Good afternoon, good morning from London. So yes, as Simone said, I'm Alex. I'm the head of Healthy Weight, Food and Nutrition Strategy and Governance within the now new Office for Health Improvement and Disparities, which sits within the Department for Health and Social Care within the UK government. Can I have the first slide, please? So I'll sort of try and keep it sort of very brief so that we can move on to sort of the wider panel conversation as soon as possible. But just in sort of a nutshell, tackling childhood obesity has been a priority, particularly within England for a number of years. The first childhood obesity plan was published in August 2016, and further iterations of that plan were published in 2018, 2019, and then a more holistic strategy for obesity, combining both child and adult interventions, was published in sort of July last year. And we look at sort of three buckets of interventions at the moment within our sort of strategy, which is organic and tries to sort of move and evolve in line with evidence and public discourse. The first is sort of what can we do in the regulatory space to put restrictions on unhealthy food and drinks. So for example, advertising, promotions, calorie labeling, that sort of thing. The second bucket is around reformulation. So how can we make sort of the food environment that we have healthier? And we have two particular programs focusing on sort of sugar and calorie reduction. And the third is a sort of a new element of our program, which is piloting child weight management services across 10 and 11 local authority areas within England. It's sort of a pilot program for this year, and we'll be sort of evaluating the evidence and considering how we can take that forward in the future. Next slide, please. So it is a long journey. It's a huge challenge in England, in the UK, but also within the world. But we have seen some successes within the policies we've been able to deliver so far. So looking at sort of reformulation, the introduction of a tax, so the soft drinks industry levy has seen a reduction in the sugar content of drinks within its scope by about 43.7%. It has also been a very useful revenue raiser to be able to put into interventions to support physical activity, particularly within schools. We've also done a lot sort of on the regulatory side. So we now have out-of-home calorie labeling, which is brand new and will come into force from sort of April 2022. So that has completed its legislative process here in the UK, and also going through the legislative process are sort of quite robust advertising restrictions that are covering both broadcasting but also online sort of routes of marketing. Next slide, please. So there are challenges. I mean, there are always challenges within sort of the policy space. And I think particularly within a public health challenge as big as obesity, where there is such passionate and sort of energetic public discourse. So the sort of four buckets that we've identified that would be sort of, we want to sort of highlight as sort of challenges for us. One is sort of causality. So how do you prove impact and change? The second is sort of being the guinea pig, going first, taking the risk and trying stuff out is always a sort of a challenge, particularly within the policy space and taking people with you. The third is behavior. How can you evidence behavior change, again, to support sort of future policy development as things evolve? And the fourth, because of the energetic and really exciting public discourse that we have in this space, how do you find the common ground? How do you make sure that you can take everybody with you and find the right sort of solutions for the problems we face? And based on those, a few very quick reflections before I stop. Number one, I suppose making sure that we encourage as much diverse debate on this topic as possible, because that's the only way as policy officials we can sort of do the best that we can to make the right interventions. The second is knowing where we have the evidence limitations and developing sort of strategies to address those. Thirdly, sort of partnering with sort of the latest and best thinking, both within academia, but also sort of patient groups. It's important we listen to sort of all voices in this. And then also sort of come back to the going first point, actually being willing to take the risk and to try things out. It's important that we are able to try and know and learn the lessons from sort of either what works and what doesn't, and to share that as sort of widely as we can. So I'll stop there, and I look forward to sort of the discussion going forward.
Wonderful, Alexander. Thank you very much for your presentation. And now we are going to move to a presentation for advocating for patient-centered care during COVID-19 by Alina Constantin from the Ligue contre l'Obésité. I hope I say that well. Patient advocate engaged in patient-to-patient peer support, president of a local patient organization since 2017, member of the Patients Council at La Ligue contre l'Obésité, the League Against Obesity, since 2020. The floor is yours, Aline.
Thank you very much, Simon. I think you can go to my first slide, please. So there you can have a look at our organization. It was created in 2014, and it actually spread off really well because there was there was a need in the French in our French country for this type of organization. So today there are 75 patient organization members. And what I would say is very important is that we are regrouping all players in the field of obesity, health professional researchers in both medical and social sciences, and also patients. Of course, there is a scientific council who counts physicians and surgeons and researchers, and also the Patients Council, who's formed by patient representatives from different associations. And they have different missions who complete each other. Next, please. Some of our most important actions as the League are a hotline for people living with obesity. I will speak later a bit more about it. And also an educational center where obesity science and therapeutic education courses are provided, providing access to relevant information. We help people address internalized stigma and learn how to handle themselves and where to go, for example, for specialized healthcare. And also we did a national survey who was funded by the League in 2021. That wasn't done in France for about 8 years. And also the World Obesity Day France was rewarded by the ESO in 2021. We had the opportunity as people living with obesity and patient associations to showcase a new narrative on obesity, and because we counted more than 35,000 kilometers in 4 days, from people's physical activity all over France. Next, please. So the hotline, what I would like to talk about today is the fact that we had this holistic action plan throughout the COVID-19 pandemic, trying to support people with obesity and to take advantage of the fact that it was an important occasion to speak about it. Therefore, we created at first, as a first need for people with obesity, a hotline providing support about their healthcare during the pandemic, and also about their situation as employees. Because at first there was part-time unemployment who was offered, as well as remote work, and then not anymore. So we had to come in at that moment. So becoming a mediator is important because we heard firsthand what people lived in their real life. And so we could translate that before the authorities. Therefore, we fought for the inclusion of vulnerable populations. And our first mission was to get recognition for people living with obesity as a group that needed support during the pandemic, among other people living with other NCDs and chronic disease. At first, during the first lockdown, we had the possibility to ask our physician for the partial unemployment. Then, unfortunately, in the second lockdown, the government refused to include us on the list of vulnerable population. So we had to go back to work as everybody else, not having any chronic conditions. So that's where the League reacted and raised the issue before the Council of State, who is the supreme administrative jurisdiction in France and settles disputes between citizens and public authorities. So we addressed the inequity of the law before them, and the Council of State ruled in our favor. After that, lawmakers still excluded the consideration for people living with obesity by letting the work physicians take the decision for partial unemployment case by case, while that was not the case, not the same for other chronic illnesses. So it was a halfway victory, but at least we managed to pull obesity in front of public attention and the attention of the authorities. After that, there was the vaccination schedule. Vaccination began during winter in January and February, and it was the logic behind the strategy was the bigger risk population had to be vaccinated first. It was age and chronic disease combined. So people living with obesity who did not have other chronic conditions and were under 50 had to wait for a very, very long time, for another 3 or 4 months before being able to get vaccine. Therefore, the LCO was very present in the media. It was a very big campaign with national and TV and radio, local stations, everywhere through patient interviews, and also from our lead representatives, of course, and also in written press. We also lobbied in the different stakeholders, such as the Orientation Council of the Vaccination Strategy, and the High Health Authority, the HAS, as well as the Ministry of Health. And the outcome of this collective action from both League and the other stakeholders was the prioritization of people living with obesity in the vaccination program. So we were able to get vaccines at the beginning of May. Next, please. So, of course, there are many challenges also in France. And what I would say the first is systemic weight bias and stigma. Because of the myth, move more, eat less, that is still very present in public policy. And that puts the blame on people living with obesity. And that also prevents, as a side effect, it prevents people living with obesity to stand up for their rights and to get out of the negative cycle of auto-blaming and shame. So, of course, we also fight against the limited recognition of obesity as a chronic relapsing disease. It's not yet recognized officially as being such, and that has an impact on how the healthcare is reimbursed, healthcare insurance resources, and also the medical research are not nearly enough in comparison with other NCDs. Another problem, systemic problem, is a limited medical education about obesity for primary care physicians, and a lack of specialized healthcare. And of course, there are not enough non-governmental organizations and patient associations to act locally, offer information and support to people living with obesity, which is for us very important to support. Patient associations are like the veins from our system, and getting the blood flow everywhere. So next slide, please. What we've learned in this whole situation was that we really needed to incarnate people living with obesity and represent them and become a main player, and therefore thinking at all times, having this militant side where we have our people in mind at all times, and reaching authorities through both mediation and representation, and have a lot of strength and courage in raising our voice and defy authority when arbitrary decisions are made. Of course, what happened is we try to grasp every opportunity in the existing system, and get things done whenever it was possible.
Alina,
yes.
We are running a little bit out of time. If you could,
yes,
please.
Sure. Well, what I would like to say is that there are several ways to do things by being very present and attracting media, and being reinforced with partners and allies, and becoming a leader, actually. Yeah, that's what we tried to do, and I hope that we will continue to work as it did the last year. And thank you all for listening.
Thank you very much, Alina. It was very interesting case study and wonderful identification of challenges and recommendations. I think we can go back and discuss a little bit more at the end. And now I am going to give the word to Amanda Baker, who is a public policy analyst at Elige Vivir Sano, Choose to Live Healthy, in the Ministry of Social Development and Family in Chile since February of 2020. She's going to tell us a little bit about the system's approach to addressing childhood obesity, and Chile is one of the leaders in Latin America in child obesity prevention policy. So it will be very interesting. The floor is yours, Amanda. Thank you.
Thank you, Simone, and a huge thank you to the World Obesity Federation for the invitation and for organizing this policy laboratory. It's really exciting to be here and share the space with such great institutions. So I'll start off with an overview of Elige Sano. If we could go to the first slide, please. So Elige Sano is a public agency within the Ministry of Social Development and Family in Chile. It was created by law in 2013 with the aim of promoting healthy behaviors to improve the quality of life and well-being of the Chilean population. And some of the specific objectives include the promotion of healthy eating and physical activity. So the cornerstone of our work is the Elige Sano system, which is a management model of policies, plans, and programs that encourage healthy habits and diminish factors associated with non-communicable diseases. So the initiatives that make up the system are implemented by different ministries and are updated annually following consultations with the agencies involved. Some of these measures include the program to monitor compliance with the food labeling and publicity law from the Ministry of Health, for instance. There's also a program for the Ministry of Interior to construct, repair, and improve urban areas to facilitate physical activity, installing more green spaces and active plazas. So the system really takes an intersectoral approach, understanding that obesity is not just about the healthcare system, it's also about urban development, it's about agriculture, it's about education, and it's related to all of the actors listed here on this slide in some way. So to address malnutrition in younger people more specifically, in 2019, Elige Sano launched its zero obesity strategy with the aim of stopping the rise in obesity rates in children and adolescents in Chile by 2030, with a focus on improving dietary and exercise habits. This year, there are 19 different initiatives from different ministries that make up this strategy. One example being the construction of sports centers in low-income areas to facilitate access to spaces where people can exercise safely and conveniently. Another example is the expansion of farmers markets, which offer healthy foods at lower prices than supermarkets in Chile, and also encouraging those markets to open during the evenings so that people can access those spaces after work. So if we can go to the next slide, please. Thank you. Some of our achievements include, firstly, the National Food Security Plan that was developed in 2020. This is composed of 29 different short and medium-term measures from different ministries with the aim of mitigating the effect of the pandemic on food security in Chile. So some of the measures included government donations of healthy foods to community soup kitchens, or the creation of a mobile phone application called Healthy Deliveries that could be used to order healthy foods from local farmers market and have it delivered at no cost or low cost to people's homes, just trying to ensure access and availability of healthy foods even during the pandemic. And a more long-term achievement has been the creation of the Elige Sano Observatory. This is our data analysis branch tasked with monitoring population trends and initiatives that are part of the system. And the first steps have been to systematize existing surveys from different ministries. So for instance, the Ministry of Sport publishes surveys on sedentary behavior, the Ministry of Health publishes surveys on food consumption, the Ministry of Education publishes information yearly on the nutritional status of children. And what the observatory does is collect the relevant information from all those different places and put it in one place in an online platform and organize it by different categories to be able to say, right, these are the obesity rates in children, and this is the information that we have on the factors that are associated with it. Lastly, we have the Healthy Environments Fund, which allocates financial resources to projects from community organizations that will make environments healthier. These can include implementing school and community gardens or coordinating sports activities according to the characteristics and needs of different regions. So even if the name Choose to Live Healthily might make it sound like it's focused solely on behavioral changes on an individual level, we do understand that environments play a critical role in the development of obesity and that they will have to play a critical role in the effective treatment and prevention of obesity. Next slide, please. In terms of challenges, the Chilean context in and of itself remains extremely challenging. According to the most recent national surveys, almost 3/4 of the Chilean population over the age of 15 were affected by overweight or obesity, and over 15% of children have overweight or obesity. It's likely that those numbers have gone up in the midst of the pandemic in light of lockdowns and decreased access to healthy foods and opportunities to exercise. Next slide, please. So in the face of these challenges, a good starting point is to establish an agency tasked with coordinating different initiatives from different sectors dedicated to obesity prevention. This is, of course, easier said than done, but it is possible, as Chile has shown. And lastly, adopting a systemic approach that takes into account social determinants of health and that additionally takes into account not just the person, but also their environment and all of the factors and actors that make up that environment is critical. And that is all from me. Thank you so much.
Thank you very much, Amanda. As always, Chile is a very interesting case for all in Latin America. You are a leading country, and it's very interesting to see the progress. Now we are going to go around some questions, and maybe I will like to put a preliminary question for each of our three panelists. So in the case of Alex, I would like to know if you can tell us a little bit more about how are you thinking to prove impact. I think in this kind of obesity prevention policies, the impact is very complex because we are talking about real life. So sometimes the people that is against this interest of obesity prevention policies would like us to develop random control trials and have a very well-designed experiments to prove impact of these policies, which often is not the case. So I would like to know, what do you think about how are you going to prove this results? For Alina, I think it will be very interesting to mention a little bit more about this movement in which many groups are denying obesity as a disease, and what are the consequences of this, or what is the position of your organization regarding this discussion, which is a complex discussion, and I think many groups around the world need to learn what are the advantages and the disadvantages of this. And for Amanda, I would like to know, if possible, if you could discuss a little bit more what are the complexities, the main challenges to the implementation of these policies in Chile. In my experience in Mexico, one of the biggest is food industry, junk food industry interference in implementation. Obviously, there are many others, but I would like to know what are your insights, or what are the main challenges right now for this complex system implementation. So I don't know, Alex, if you want to start. Thank you.
Yeah, thanks, Simone. It's a great question. I mean, causality is very, as you say, it's very difficult. Not only is the health challenge complex in terms of obesity, but it's also the fact that there's the lag time, particularly with sort of showing impacts. You introduce policy, it will take a number of years to show effect, particularly through generations, as you're showing it sort of over the life, cycle of a population. One thing we do, though, have that I think is quite useful particularly within England, within the UK, is we have what is called the National Child Measurement Programme, which enables us to track in very, very accurate detail the actual prevalence and trend of obesity amongst childhood. What that is an annual programme in which every child within England is measured at school for their height and weight to obviously get sort of the BMI score, and that then feeds into sort of the trend of obesity at any given point in time, and also feeds into sort of the primary care system within sort of England, so that sort of preventative action and programs can be acted on based on sort of real-time data. So that's sort of our core sort of basis of measuring impact in terms of trends. In terms of the specific effectiveness of policies, and I think coming back to the point I said about going first and trying new things, that is even more complex. And what happens is we undertake sort of a post-implementation review of policies that happen, where we assess against a range of indicators how things are happening. So we don't necessarily do sort of specific control trials. We look in the whole picture of exactly what policies have done, how they have been successful, how they have not worked so well, and then use that data to either improve the policy that we've got, or to feed into the sort of the future policy development of what is coming down the line. So for example, if we take advertising, we're taking specific action amongst TV and online forms of marketing, but there are other avenues. So our post sort of implementation review would look at sort of how that data could push us further in further marketing restrictions if we wanted to.
Thank you very much. That's a very interesting response, and I think gives us a lot of ideas of what we can do. And I took note about the National Chart Measurement Program, which I think some countries in Latin America and many other countries are doing it, but many countries are not doing it. So it's very important. And Alina, would you like to mention something about the question I raised?
Yes, of course. I think the recognition of obesity as a chronic relapsing disease in France seems today as being almost impossible at the government's level. We feel that like there is it's like we are not going to be heard, even if we try to as an organization to empower people with living with obesity. And I think that is because of the mentality that we still have about obesity, and the fact that people are considered to be guilty morally. That is more of a moral problem than a medical one. That might seem like not how should I say that? I do have problems with the English, I'm sorry. I think there are big forces at play where we try to make this happen. And I think it is going to happen step by step. Like we would try first to have recognition and reimbursements for healthcare for people with a BMI over 40 in order to get the complex obesity and the very complex obesity as a chronic disease. I don't think in France it would be possible to get recognition all of a sudden, and because the system, the healthcare system in France is done in a way that it would be very costly to cover all healthcare for 8.5 million people living with obesity today in France. There are new guidelines in the making right now at the High Authority of Health that started in 2019 and most likely will finish in 2022 or early 2023. And they're trying to take into consideration the state of the research based on the COVID-19 pandemic epidemiological data. I think there is hope about that. I mean, we are not likely to get recognition right now, even if we are trying to build a momentum. Maybe I will have a great surprise by having that by not being right, but I'm afraid that we need to make more collective action and continue to be very active as an organization and try to lobby more to get this done in France.
Thank you very much, Alina. I would like to see if Amanda has some insight on my question. Yes, please.
Yes. Thank you, Simone. I think firstly, problematizing obesity is still a challenge in Chile. Chile went through its nutritional transition really quickly. So we have grandmothers, for instance, who still believe that children with overweight are healthy children, because in the grandmother's generation, children who were underweight were often very unhealthy and even had high mortality rates. And with the rates of overweight and obesity being so high, it's about 74.2% of the Chilean population over the age of 15. For many people, it's very normalized. So it's really important to communicate those risks and ensure that people have the information that they need to make healthy decisions. And I would say, secondly, the lack of access to healthy foods and possibilities to exercise due to the lack of time and lack of resources. A lot of people in Santiago, for instance, have to spend 2 hours to get to work and then 2 hours back, and it's difficult to include going shopping in that day or cooking in that day. So those are topics that need to be addressed with the Ministry of Transport, with the Ministry of Labor. So there is still a lot to be done, but progress is being made. For instance, a few weeks ago, a bill was introduced into the Chilean Congress to recognize obesity as a disease. And we are still working within the Higiro system to address issues of access. Thank you.
Thank you very much, Amanda. Well, we need to move to the next panel, but I would like just to mention that there are many interesting questions in the questions and answers, and maybe the panelists can respond. There is a very interesting question by Luke Hagenars about the body positivity movement, which I think is something that we need to discuss a bit more. By Rudy Kailat about the effects of these policies and how can we evaluate them, which is something we discuss a little bit, but not much, by Teresa Rodriguez, and another additional question. And it will be very interesting to know more about the marketing restrictions in the UK, which Alex mentioned as some of the best in the world. So it will be nice to identify which ones are. But now we need to move. So I am going now to introduce a discussion panel to discuss the road of the future, opportunities, obstacles, and actions. How can we collaborate better and learn from each other to improve efforts to address obesity? And for this, we have 4 very bright colleagues from different parts of the world. We have Jacqueline Baumann-Bussato from the European Association for the Study of Obesity in Brussels, and she's a policy lead at the European Association for the Study of Obesity and a patient council member. Also, Leslie Behar from my institute, the National Institute of Public Health, and she's a nutritionist who currently works at different parts of the food environment and different research projects and weight stigma, etc. Then we have Tasha Makayakora, who is a youth representative of Bite Back to 2030. She's a youth activist from childhood obesity prevalence and prevention, and she campaigns to break down barriers and disparities in the accessibility and availability of healthy food and adolescents. And finally, Santi Gomez from the Gasol Foundation. He's the head of the programs and research at the Gasol Foundation. And well, I would like to give first the word to Jacqueline Baumann. She's going to say to talk a little bit about how can we improve scientific and public-facing language and communication support for collective action to address obesity. The floor is yours, Jacqueline. And you need to open your mic, yes.
Indeed. Thank you so much, Simone. I'm going to try and keep this extremely short because I could speak about this for an entire hour. So there are 3 main points which I'd like to open with. And I would also like to firstly put a proviso there because people don't quite realize when I make all of these broad statements. So 26 years in public health and healthcare policy, also a bariatric patient, someone living with obesity for over 20 odd years, and also co-founder in my spare time of the Belgian Foundation for People Living with Obesity. So with that, and also EASO policy lead. Now, 3 points. Firstly, language. What I wanted to say there is that actually the bottom line is that we need a common understanding which goes way beyond how we express ourselves, because what we have seen, and I've given some of the research that we've been doing, what we have seen is, and it came out as well in some of the previous presentations, is that there is no one source of truth in terms of what we're talking about. I want to give you that source of truth very quickly, which is a WHO definition of obesity, which is overweight and obesity are defined as abnormal or excessive fat accumulation that may impair health. That is since 1948. It's not about BMI, it's not about weight, it's definitely not about only food and nutrition, which takes me on to my next point, because thinking about language based on the definition and how we move forward with policies and completing that policy picture, it's about, are we talking about obesity policies or policies that can actually affect obesity as a disease, as per WHO definition? Currently, obesity policies, to put it bluntly, are actually a euphemism for nutrition policies and primary prevention of weight gain. That is only part of the picture, only part of the picture. And then the other element is that if we had one source of truth where we were actually able to, if you like, flow from the WHO definition, as opposed to cherry picking different elements, that a lot of really great research has been done, but actually no overarching context is ever placed there, ever, then I think we would actually be starting to untangle the complexities of how do we actually see some results, not just in terms of obesity prevalence, but in terms of, as Alina rightly pointed out, actually working out where to go first in terms of severity, how to get that under management, and so long-term management, and also, you know, what elements, existing interventions can, for which is basically primary prevention, would also be useful in the treatment and long-term management of obesity. So unlike, or to push back a tiny bit on what Alina said about recognition, actually, the European Commission in 2021 categorized obesity as a chronic disease. I can send that link as well. And they said pre-obesity, brackets overweight, and obesity are medical conditions marked by an abnormal and or excessive accumulation of body fat that presents a risk to health. Obesity is a chronic relapsing disease, which in turn acts as a gateway to a range of other non-communicable diseases, such as diabetes, cardiovascular diseases, and cancer. So my devil's advocate point is, let's actually start from those basics and put all of everything else that we're going to discuss as a panel in context and start to see the results.
Thank you very much, Jacqueline. Very interesting, and I'm sure I will also love to listen to you for 1 hour discuss about this. It's very interesting. And now I would like to give the floor to Leslie Bejar from Mexico. Leslie, can you tell us a little bit your insights on this topic, please?
Thank you, Simone. I agree with you. It was fascinating to listen in Jacqueline's intervention. And thank you to Wolf for the invitation. It's a pleasure to be here. And I would talk a little bit about breastfeeding, which is a very important topic. The first 1,000 days of life are crucial for obesity prevention, because we're talking about obesity. And despite significant efforts to raise awareness on the importance of breastfeeding, currently rates are alarmingly low, and not just in Mexico. So many mothers, baby, and even the planet is missing out of the benefits. And in Mexico in 2018, the prevalence of exclusive breastfeeding doubled compared to 2012, but Mexico has one of the lowest rates of breastfeeding in Latin America. Early initiation of breastfeeding in Mexico is 48%, but the proportion of children under 6 months of age who are exclusively breastfed is only 28%, which is lower than both the regional, that is 30%, and the global 48% prevalence. And there are a number of important barriers that limit the promotion, the protection, and support of breastfeeding in the country. And they are both cultural, health services, and public policies related. However, low global breastfeeding rates, and I must say globally, can be partly explained because of the exposure to aggressive marketing tactics of the breast milk substitutes industry, which is shown to reduce breastfeeding initiation and maintenance. And regarding the cultural barriers, they can manifest in people as little or no confidence to be able to produce enough milk. And they can also manifest as social barriers, for example, different beliefs, low emotional support, or social norm around breastfeeding. For example, if it is not well seen that a woman can breastfeed in public, like in Mexico. And the clinical practice in hospitals in Mexico violates the International Code of Marketing of Breast Milk Substitutes. And these, of course, affect breastfeeding. And in hospitals in Mexico, there are breast milk substitutes, and there is exposure of mothers to formula advertising in here. And furthermore, it's important to mention that in Mexico, only 14% of hospitals are certified as child-friendly hospitals. And there are also barriers related to the health services because of the lack of training and in health professionals and everyone that is involved in breastfeeding. And these kind of get more intense because of COVID-19 pandemic. They kind of move from different services and to attend this pandemic. It's important to mention that 48% of mothers in Mexico referred that the doctor's recommendations was the main reason for them to introduce infant formula to their kids. And 44% of mothers attribute that these to scarce information of breastfeeding techniques and immediate postpartum period. And the thing about doctors' recommendation is very important because there is a very big conflict of interest that we can discuss even more in depth after. And I must say that despite the fact that Mexico has subscribed to the code since its initiation, since its creation, there are no actions on its implementation and monitoring or sanctions for non-compliance. And one thing that we can see globally is the increase of use of internet, of social media, of marketing through influencers, which represents an possibility to exposure to the digital marketing to breast milk substitutes. And they often break what is stipulated in the code, and largely because they are little regulated. And last but not least, there are a lot of weak policies to support breastfeeding in the workplace. For example, in Mexico, the paid maternity leave for woman workers in the former sector has increased from 12 to 14 weeks, as is established by the International Labour Organization. However, it is far from the 24 weeks that are recommended for to have a better breastfeeding uptake. And in addition, only fathers, they only have 5 days of leave. So one recent success in Mexico was the approval, but just in the judicial branch, of a paternity leave of 12 weeks. So we have a very big gender gap, and this might help to increase breastfeeding rates. And well, we have been working a lot in breastfeeding policies, and there had been a recent document of recommendation that was made by the National Institute of Public Health, by UNICEF, WHO, PAHO, and FAO of recommendations of national, state, and local public policies to prevent, to control, and reduce malnutrition in children and adolescents. And this, of course, takes into account breastfeeding. And there has been a lot of research from the National Institute of Public Health, like about marketing of digital marketing of breast milk substitutes, strategies of M-Health, and some interventions in indigenous populations to try to increase breastfeeding rates. Thank you.
Thank you, Leslie. A topic very relevant for obesity prevention, and one in which we have 4 years of an international codex, but not really the results we need. So we need to push a lot in that. And now I am going to introduce Tasha Makayakora, who is going to tell us a little bit about her work on obesity prevention and disparities and breaking down the barriers. Tasha, the floor is yours.
Fantastic. Thank you so much, Simone, for that introduction. And thank you so much to the World Obesity Federation for organizing this laboratory and for inviting me to this amazing panel. So the key question posed to me is on the factors that I think contributed most to some of the work that I've done with Whiteback. So we've led and had some really promising successes in terms of campaigning on a wide range of issues, such as provision of free school meals over the lockdown last year, but also the 9 p.m. watershed on junk food that was introduced as part of Boris Johnson's obesity strategy earlier this year as well. I think the first contributing factor there is emotion. And to explain a little bit more with regards to our free school meals, we had almost 450 people sign Christina's petition, and the campaign had an estimated media reach of about 21 million, and alongside the petition. And I think it's not a case of, every single one of these people that signed the petition at some point were on free school meals, but rather the campaign resonated with so many people alongside those that had experience with being on free school meals. And so for me, it wasn't a case of, somebody that supported the campaign based off their experience, but rather they just simply needed a heart to realize that 1.4 million children, of which were from one of the most deprived backgrounds, deserve to have at least one healthy meal over the Easter, May, and summer holidays as well. So making sure that each campaign is not just about proposing this problem. Of course, childhood obesity is a problem, but in terms of getting more people to support the cause and getting more people to realize that this is a problem, it's all about emotion and making sure that emotion comes across in every single campaign. And I think the second contributing factor is mobilization. So at Bite Back, we want to know the truth about the food system, how it's designed, but also most importantly, look at how can we redesign it to make sure that young people's health comes first. And I think in order to do that, we need to recognize the need to build a powerful alliance with key stakeholders that can make this redesign a reality. So this means not only reaching out to other young people who are just as passionate as myself, but also reaching out to parents, government leaders, businesses, other NGOs and charities that are working within the food system to literally implement the same change that perhaps I'm pursuing as well. And I think every successful campaign brings together as many stakeholders as possible to raise people's awareness of and demand for change. And finally, I think the most important is making sure that young people's voice is included. So for many years, talks that aim to tackle childhood obesity have lacked the youth representation that is needed. And ironically, young people have this desire and enthusiasm and capacity to transform the world and are looking for opportunities to do so. In fact, if we look at some of the major social movements in modern history, a lot of them have young people at the heart of every conversation. And so I think it's very, very important that that is reflected in any childhood obesity discussions, policy discussions. For example, in our latest campaign, #SpillTheBeans, this aims to really reveal the truth about what is on our plates at school. What are children really eating when they're at school? And so it's important to have young people involved, because at the end of the day, they're spending 190 days in school, and they're the ones that really know what's going on within their school gates, right? And so to make sure that young people's opinion and thoughts and ideas are reflected is really important. And in terms of how young people experience the food environment. That's a lot different to somebody that is, 10, 20, or even like 30 years older than me. How they experience and interact with their food system is a lot different to how a young person would experience it. For instance, I know growing up, after school, you'd go to your local chicken and chip shop, not because I was particularly hungry, but rather it was a social thing for me to do, right? It was a great way for me to meet with my friends and just chat. Whereas, another generation might not might not go to their local chicken chip store, but rather choose a more upscale store, but simply might just go, even if they do decide to go fast food restaurant, it's not for a social purpose, but rather, it's just grabbing something to eat. So making sure that young people's experience in terms of how they interact with the food system is really, really important in terms of addressing the childhood obesity that we have. Once again, thank you so much for having me. And I'm looking forward to some of the questions that we'll be discussing today.
Thank you very much, Tasha. Very interesting also. And we take this point. It's very important to have the voice of young people. I don't think there are a lot of countries that are doing it. We need to emphasize these components. Thank you. And now we are going to close with Dr. Santi Gomez from the Gasol Foundation, and he will give also a very important perspective in obesity prevention, which is like physical activity and intervention programs in children. Santi, please, the floor is yours. Welcome.
Thank you, Simone, and thank you to the World Obesity Federation for inviting the Gasol Foundation to this webinar. And thank you, Jacqueline, Leslie, and Tasha for your contributions. Are highly inspirational for all of us. And I would like to highlight what makes a successful partnerships when we are implementing public health initiatives, public health programs. First of all, I would like to highlight that inside the national plans to prevent childhood obesity, it's important to take care about regulations and politics that can modify structural factors, but also under our opinion, it's important to highlight the importance of local environments and municipalities to fight against childhood obesity, because municipalities are the settings where the multi-level and multi-component interventions, community-based interventions, can be implemented. And under our opinion, it's important to be able to activate the intrinsic motivation of all the local key stakeholders that can be part of these community-based interventions implemented through municipalities. And this point is crucial under our opinion. And I am meaning to activate the intrinsic motivation of, for example, educators from schools and social entities, or the intrinsic motivation of health professionals, like the professionals that are working in primary care centers, hospitals, but also the officers and politicians from the city councils, and also coaches from sports organizations, for example. All of them are important to have success with our childhood obesity preventative initiatives. And for activating their intrinsic motivation, their real motivation to be part of this community-based intervention, it's important first to communicate to them and to give them the opportunity to understand the importance of their role to have success with the community interventions. Also to highlight the value, the differential value that they can provide to the full intervention from their setting, from their local setting. Also, it's important to communicate to them and to promote to them the importance of feeling that they are part of a bigger intervention, and also that their contribution, it's important, but it's something additional to all the contributions that all the local key stakeholders should provide to the interventions. And also, and most importantly, it's important to guarantee that they enjoy their participation inside the community-based interventions. All these 4 points are, for us, for the Gasol Foundation, crucial to be able to build successful childhood obesity prevention initiatives.
Thank you very much, Santi. And yes, this is a perspective that probably is also essential to the obesity prevention, which is to think not only like in the families and individual, and not only at the big policy level, but we need the local level, the built environment, and to consider this an essential part. And I think it's a big challenge in many populations. Just to have this discussion and to have this topic in the table is not as easy as we would like. So we have an initial position from all of you on some of the key factors that we need to prevent obesity, and now it will be a time to have an open discussion, and I would like just to throw some ideas of what we could discuss. So one of the first one, and it is going back to Jacqueline, but feel free, every one of you, to participate also. But it's how we improve the language and the communication to have this collective action. And I think the groups are like given the different interests involved in the problem. There are voices going in different routes. So we face, for example, in Latin America, groups saying, no, we don't want to discuss this as a problem of health. We don't want you health professionals to tell us that this is something we have to change, and they are getting a lot of traction. And we don't want really to fight that. We want to improve the understanding. So yeah. What would be your thoughts on how can we do this and don't lose this narrative?
Exactly. Well, I would say as well, I'm actually South American by birth. I'm Guyanese. So I absolutely hear what you're saying. I'm on my third nationality now, but yeah, via Brexit. But basically what I would say is what we've seen within EASO, and we cover 36 member states of WHO region. So we have a very diverse set of cultures. But actually what we've seen is that it's all about people's starting point. When everybody just assumed that we know, myself included when I started, well, I know what I'm talking about when I'm talking about obesity. You would be amazed at the amount of people who hadn't actually seen the WHO definition. Once that was actually out there as a basis for discussion, and once we actually had very accessible, particularly for policymakers and the stakeholder community, a literal explanation of onset of obesity, as well as the main causes. And for adult obesity, we're talking things like endocrine disruptors, we're talking, or endocrine system issues, some medications, mental health, sleep, and all these sorts of things, stuff which we wouldn't normally even mention in the policy debate. But we had some very, one-on-one and Q&A, question and answer sessions, so that stakeholders could actually ask those questions to have the knowledge, because that was the first thing. And more recently, because again, we realized through various channels that we were all throwing, most of us are not native English speakers, so we were all throwing around these words and concepts interchangeably, and it was really, really confusing. So we're actually working on a taxonomy, so a vocabulary classification and usage exercise. We've already started that within an EU project, and we're moving it through. So that it's not to try and convince people one way or another. It's to say, here is a full picture. Now you can actually start the discussion at the same point that everybody else is starting that discussion, and it's all evidenced. Because at the moment, what seems to be happening, and we've published on this, I can say it, what's happening is we lump obesity together, regardless of childhood. We copy paste solutions for throughout the life course from a policy perspective. We don't take into account the fact that according to the Lancet Commission, only 4.3% of the entire global population has a clean bill of health. Talking only about primary prevention, we're talking to less than 4% of the entire world population. That's where we are. In Europe, 59.3% of the population has pre-obesity and or obesity already. The prevention boat has gone. But because the only thing in policymakers' armory is primary prevention, because we've been really good at collecting data and having those discussions, actually, even if they say, we know this is important, they don't have the vocabulary or the concepts to be able to go beyond prevention and actually extend that into treatment and long-term management, which means, shall we say, dealing with the genetics for the next generation. And then we see the prevalence rates going up. So that's why I say it all starts, it's a vicious circle, but we need to start with understanding and actually the vocabulary. That, I mean, it's been hard. I have cried in meetings listening, and then I suddenly got this eureka moment whereby I said, okay, this is about language. Let's see what we can do.
Yes. Thank you, Jacqueline. I don't know if other panelists want to comment. Yes.
Yeah, if I could just add on to that point on language, I think also when we're talking about public health, any public health issues, so not just, obesity or childhood obesity, I also think that excessive use of jargons and abbreviations can be really off-putting to like the general public, right? And I think a lot of the time, especially for like young people, it can often be received as, oh, this health professional, this actor is coming from some form of like moral superiority. And I think that can really disengage people within the conversation, especially young people, when we're trying to get them more involved within the food system and really thinking about how can we transform it. And so I think what's really important is making sure that we're using simple language that makes the topic more accessible, especially when we're talking about reframing that language from, individual responsibility to collective responsibility and collective action, making sure that we simplify that conversation as much as possible to ensure that it's digestible to everyone, no matter what age you are, what profession you are, what background or history you're coming from, so that everyone can be involved and take part in this action.
Yeah, I would actually push back a bit, because simplification is what got us to eat less, move more, unfortunately. So we've actually been pushing for precision. So precision allows us to be scientifically accurate, but accessible and also respectful, which means people first as well. So if we're saying that I have obesity regardless of my size because I've got lots of biological mechanisms, in my case, I've got a lot of kit in my body, so you may or may not notice that I have obesity, but actually I can shrink those adipose tissue, so the bad fat, but I can't get rid of them. So I'm living with this no matter what. When you actually start being precise, then everybody understands the same thing. But when we simplify, trust me, there's a lot of the science, or should we say the scientific jargon that, I'm a lawyer by education. I do not understand it. And I know that your average policymaker does not understand it, because what they say to me every single time, like regular people, is, okay, love the story. Is it backed up by evidence? I say, yes, it is. They say, okay, great. Give us the footnotes and we'll move through. And that's what people need, but they need it to be precise and accurate and, to have a picture. So I push back a bit, but I completely agree with what you're saying.
Thank you, Jacqueline. And now, Santi and Leslie, I don't know if you have a comment about this. And also, I would like to introduce a little two other elements, just in case you also want to comment, which is the importance of there is a comment in the panel in the questions and answers about physical activity, about if physical activity has been introduced to prevent obesity, like a solution. And there, I think there are groups that treat these interventions like as isolated components. So you see very often, for example, in Latin America, physical activity interventions, often sponsored by junk food industry. So I think it's a challenge to see them isolated, but I would like to know your insights. And also, if you want to comment something about youth and digital marketing, which I think is a growing problem. It appeared like a mushroom from one day to the other, and now we have this problem all around the world, and it's very poorly regulated. So I don't know, Santi, Leslie, and then Tasha and Jacqueline, if you want to do a final comment. We are running a little bit out of time, but the floor is yours.
Yes, of course. Regarding the comment from Jacqueline and Tasha, I would like to highlight also that a lot of times the treatment interventions applied within young people are prevention interventions, because they have the potential of modifying certain genetic and psychosocial characteristics of these young people that then will be transmitted to the future generations. So sensitive treatment initiatives can be preventative initiatives to future generations because have powerful to modify genetic and psychosocial characteristics. And regarding physical activity, in the Gasol Foundation, we like a lot to use physical activity as a tool, as a pedagogical tool to communicate all the healthy behaviors to children. Healthy behaviors regarding healthy eating, sleep, emotional well-being. Physical activity is a very useful tool to be in touch with young people, to communicate efficiently healthy lifestyles in general.
Thank you, Santi. Leslie?
Thank you. I will be very brief. So yeah, I totally agree with Tasha, with Jacqueline and Santi regarding the narrative around obesity. And it's important to not oversimplify it, because that's part of the problem, and that increase with bias and stigma. And regarding your question about marketing regulations and the new forms and everything, we have to be very aware that the food industry, they are evolving, they are adapting to everything. We saw it through, for example, with COVID-19, when they start to market very aggressively, not only about breastfeeding milk substitutes, but about ultra-processed products and sugary drinks, beverages. So we have to be very aware of that. And one important thing is to document this and to, raise our voice and say, they are doing this, and they are failing on the respect to rights to children, to healthy food, to be free of this unhealthy food marketing. And it is important also to try to make awareness so government can regulate these spaces, especially, for example, for influencers and social media, that it's very low, the regulation. And last but not least, it is important to, regarding, for example, that you said about physical activity, that we cannot engage with ultra-processed products, food industry, because there is a conflict of interest. They are not doing philanthropy by promoting physical activity. They are promoting their products. So we have to be very clear about this and to identify this differentiation and to stop having sponsorship from them, for example.
Thank you very much, Leslie. Well, we are running out of time, and I think we could have this seminar with any duration from 3 hours to 1 week. It's very interesting. I took a lot of notes, and I have I want to do so many things after listening to you. I am very grateful to the World Obesity Federation for organizing the seminar, for inviting these panelists. It was a pleasure to listen to your presentation and thoughts. And now I would like to give the floor back to Hannah Brinson to close. And thank you very much. And I will be following the other seminars of the Federation. Thank you, Hannah.
Thank you very much, Simone, and thank you so much to all of the presenters and the panelists. We've had such a great conversation, and I think some really interesting points came out, particularly in the discussion then around language and perspectives on obesity. And I think just kind of one message for everybody to take home is we really need to be speaking to each other. We need to be collaborating. And I think we just need to be honest with each other about what we're working on, what we're trying to achieve through certain policies, and just be really clear what we can and can't achieve, and what we do and don't know, where we're making assumptions, where we have the evidence. So thank you very much to everyone. As mentioned at the beginning, we supported these policy laboratories with a series of policy dossiers which provide a lot of the evidence that Jacqueline was referencing for a range of policies. So please do check them out if you haven't already, and I'm just about to put the link in the chat so you can have it there. Also, just a flag to look out, we have one on weight stigma, which we'll be publishing later in the year. So I think that will address some of these language issues. So I encourage you all to go and have a look. If you have any questions about them, please get in touch. So thank you once again. Look out for the follow-up survey, a future works in the recording of this, and enjoy the rest of your day. Thank you very much, and see you all soon.